So Gretchen, in your area of expertise, you deal with under-recognized population, vulnerable populations. You know we face a lot of stigma in this population. What do you think about the importance of education to overcome this stigma?
Well, I think education is critical, and education at all levels. So health providers are not necessarily aware of the day-to-day impact of stigma on the patient populations they're caring for. And that stigma can actually have an impact on their access to care, whether it's their abilities to get to appointments, ability to access their medications. These can be related to structural aspects, such as the health sector sort of neglecting these conditions. It can also be related to personal socioeconomic aspects, that in their patient population, those individuals suffering from more stigmatized conditions may actually also be those who are the least financially stable. And so they're differentially impacted in terms of their ability to access care.
And do you also see a difference in between the genders?
Very much so. So I think it's been well described that stigma sort of flows along power differentials. So if you belong to a group that's already naturally disempowered within your environment, so ethnic minorities, women more than men, poor individuals, these individuals, when they have the same condition as someone who's in a more empowered position, suffer differentially. And unfortunately, there's a compounding effect that occurs.
So in my field of psychiatry, I very often realize that especially women with children are really unrecognized, and there is an increased stigma. There's a lot of fear going to psychiatric treatment because they are really scared to lose custody over the children if they suffer from a psychiatric disorder.
Certainly, epilepsy is very problematic. Women are quite frequently in many settings abandoned by spouses, and they do fear risk losing their children as well. Of course, disclosure is not optional for a condition like epilepsy, where a single public seizure and their condition is pretty much disclosed to all. But I think the care delivery can become challenging in that, for example, we once tried to set up a standalone epilepsy clinic, and we realized it was a deterrent because attending that clinic for someone who was not disclosed publicly was sort of a risky thing. So intermixing our patient populations actually improved access to care.
You know, I see this, if I judge my field of psychiatry over all the years, I think in some of the disorders, stigma, it improved a little bit, like the accessibility, like for affective disorder, it got a little bit easier than for other disorders. And in psychiatry, I would say we have kind of a hierarchy. Like if you have, for example, anorexia or bulimia, it's much more acceptable to suffer on these disorders, and goes along afterwards with affective disorders. But it gets very difficult if we deal with schizophrenia or we deal with substance use disorder, because this is very often related to homelessness, low insurance, low money. It's getting very, very difficult, and this population is very much marginalized. So we need to try to integrate in the medical schools, in the nursing schools, the stigma related to these disorders in order to improve the outcome for them. And we also need to try to implement low threshold clinics or facilities. And we even need to go to the patients in order to improve their retention in treatment.
I'm curious in terms of, so I work in two diverse settings. I work in Sub-Saharan Africa and North America. And in both those settings, the structural aspects of stigma are quite shocking in terms of the resource allocation and the sort of health system readiness and willingness to truly invest in patient care is vastly different for stigmatized conditions as opposed to non. Is that true for psychiatric disorders and also in your setting?
I think it's very much developed depending on the cultural background, but being involved in teaching in many developmental countries, we see that it's also an power issue, because there used to be standalone clinics on HIV, on HCV, on OBGYN, and which turned out to be very, very difficult if we have facilities where we treat pregnant psychiatric sick persons. Together with an infectious disease, we need the medication in the OBGYN treatment, and we do not need the medication somewhere dislocated. So I think it's as you mentioned, a structural issue. We need to convince policymakers. We try to provide anonymous situation for this vulnerable population, that they can attend the clinics without being scared. Partly in some of the countries, even police was involved to really be watching who is going to be attending this special center. So getting the movement towards general hospitals, like we teach, having psychiatry integrated in larger hospital settings, might actually decrease the stigma for this population.
Right. And increase access, potentially.
And increase access, of course.
And that's where education becomes really critical, because then the more general care provider needs to be adequately trained to take care of these conditions.
I think it's very important to integrate this in the educational track in many different professions.
Yeah.
It needs to be, it's not only an awareness aspect for physicians, it needs to be integrated in all the healthcare professionals and, of course, in a political level.
Yeah, definitely.